All right, Corey Jo, can you see us now?
Yes, I can.
Okay, wonderful. So I am very excited and honored to introduce our last speaker, Dr. Paul Farmer. We are so lucky to have Dr. Farmer here today. He's a physician, an anthropologist, a professor at Harvard, and chair of the Department of Global Health and Social Medicine. Dr. Farmer is co-founder of Partners in Health, a pioneering group delivering the highest quality community-led healthcare in some of the most poorest places on earth, having altered global health systems to make this possible. He's written extensively on health, social inequality, and human rights, and is the recipient of numerous honors. Dr. Farmer has educated and inspired so many of us and really embodies what our humanism, empathy, justice, and Global Health Week is all about. So let's dive right in to give us the most time with Dr. Farmer from Kigali, where I think it is 4 a.m. So aloha, Dr. Farmer, and thank you.
Aloha, and thank you for that warm welcome. I'm actually not in Kigali. I'm up in the hills of northern Rwanda, and where we've established a medical school based on a lot of the ideas you just heard from Dr. Pohl and from friends there. And I certainly want to underline his point that it's a wonderful thing to work with friends. The only consolation for not being there with my own today is that if you look out the window, of course it's dark now, you see a volcano that is quite evocative of what I've seen in our most beautiful, that most beautiful part of the world. So thank you for having me. And I want to start really, and believe it or not, my colleague Ishan Desai, who will soon be going to medical school, is here somewhere else on this campus. So if I say next slide, as I'm about to, you'll know I'm not talking to some ether spirit in the air. I just want to start with a tribute to Gregory, who I'm sure has been mentioned and has been known to all, and to my friend Seiji Yamada. We've been in our own ways and on different continents and islands pursuing some of these same ideas that social justice and equity need to be at the heart of medical education. And I'm going to go back to this through a very circuitous route. I have a number of chances to speak with you all over the next couple of days. And I'm going to be talking about a very difficult experience, which is responding to the West African Ebola that began in 2013, and asking what not only the humanities, but an understanding of history, and particularly colonial history, can teach us, even in the middle of responding clinically to an epidemic that was much more devastating than it had to be. Next slide, please. Some of these points are quite obvious to those listening. They were not when I began medical school in 1984. All epidemics are social. We're living through COVID, as was just said by, just mentioned by a number of comments. These are also probably zoonotic diseases, as we all know. But this is, the claim that all epidemics are social is not even more than a linguistic one. That's what the word means. And so a focus on equity and the structures in which we're embedded, even in the middle of a teaching hospital, as I am now, are important to the response. And particularly the echoes of those inequalities in some of the policies and practices that have dominated what little clinical medicine there has been available in the colonial and post-colonial world. So I'll be digging back a little bit in history, and whether you consider that a humanity, one of the humanities, or a social science, I hope you'll bear with me. Next slide, please, Ishan. A lot of my work, I'm an infectious disease clinician. Seiji and Gregory will forgive me, but they already know the truth. Actually, most of my own clinical work is inpatient care. I work at the Brigham and Women's Hospital in Boston, where I trained. and where we founded 20 years ago the Division of Global Health Equity, and I'll talk more about how we've incorporated that into some of our teaching. And I'm not just speaking, of course, only of medical students, but of researchers, nurses, managers, and all those that are involved in the care of patients, but also those who help us in communities, particularly community health workers. These three images will be familiar to you probably, but the first is in a meat packing plant in the United States, where it was quite obvious there would be explosive outbreaks, as in prisons and other congregate settings in the United States, and indeed they were. And I hope we'll have time to talk more about what was Dr. Pohl just called the fragmented health system. Another picture is from the late 90s. This is in Vladimir, Russia, and led us to work on attacking the same problems of equity, not only the obvious problems of incarceration, where Russia really never rivaled the United States in terms of its rates of incarceration, came close. But after the collapse of the Soviet Union, there were many crises, as you might imagine, and they also involved stock out of medications and laboratory reagents. At the same time, there was a wave of criminality, if that was the word the Russians used, as people struggled to survive a staggeringly difficult transition, the effects of which we're still feeling today. But the part I will focus on is the standards of care that were offered to prisoners. And interestingly enough, the standards of care proposed by our Russian colleagues were in fact much higher than the heavy-handed recommendations they were getting from European humanitarians, international consultants, standard-setting bodies based in places like Geneva, New York, et cetera. And that is something that taught me a lesson in the 90s, that sometimes the biggest problems that we would face in pursuing global health equity would not come certainly from patients and their families or from our students and residents, but from policymakers. And they were often, as under colonial rules, sitting very far from where the patients were themselves sitting, whether incarcerated in one way or another. And the third image, I'll just call it the blue photo, I'd like you to keep in mind. This is from what was grotesquely called an Ebola treatment unit. And I want you to remember the picture. I didn't take it, although I could have taken other similar ones. It was taken by a New York Times photographer. And so it projected, I think it says very clearly that this couldn't possibly be a treatment center of any kind. And that became the heart of the matter in the struggle to improve survival and clinical management in Ebola in West Africa. But first, a look back at how a place becomes a medical desert. A medical desert is a clinical desert without the staff, stuff, space, and systems needed to respond. It's also invariably a public health desert where there isn't adequate laboratory surveillance, community health-based surveillance, et cetera, to even know what's going on. How does that happen? It happened briefly across the Soviet Union for the reasons that I've discussed. Why it's happened in the United States, we'll be talking about over the next few days, as you have been. But West Africa offers an interesting, if troubling, example. Next slide. So the rubric that I'm using here, above the rubric of humanities or social sciences, is social medicine. Social medicine, and I think Gregory and Seiji would agree, is perhaps the most expansive rubric we have. There's certainly social surgery and social medicine, neurosurgery, any kind of subspecialty medicine, community health, of course, but this is a safer term in many ways because it asks us to remember how and why social forces get in the body. And I'm going to speak particularly about racism, gender inequality, and many other forms of social inequality. How do they get in the body? And as to the tasks of clinicians, nurses, doctors, social psychologists, et cetera, how do we get them out? So the story is very interesting. If you're in the least bit interested in colonial medicine or the lack thereof, as I know many at this university are. The picture of the nun, this is a Flemish nun mourning the loss of members of her community in what was then called Zaire, a former Belgian colony with a history that is a grim one. And indeed, if there hadn't been white Flemish nuns involved, one wonders when Ebola would have been, quote unquote, discovered. The story was that in a mission hospital, and again, I'd like to use quotation marks, air quotes again, because this was 100-bed facility without a single doctor in a rural region of northeastern Zaire, where an explosive outbreak of a highly lethal febrile disease began in a clinic and spread out to community health centers. And of course, there was no staff, space, or systems to diagnose a new pathogen. The diagnoses were made in European, in Antwerp, in England, and the United States, when folks started to worry that a Marburg type virus, which had been discovered in 1967, when again, infected monkeys being used for polio vaccine production went from Uganda through London and then caused disease in the city of Marburg, which is, as it sounds, is a German city, Hamburg, Belgrade, killing, sickening a number of people working in the labs and their contacts. Now, I want you to remember that even before the pathogen was identified, it was characterized by diarrhea, vomiting, fluid loss, and occasionally hemorrhagic manifestations and late manifestations, but the case fatality rate then was about 22%. So the great majority of Europeans did not die. The epidemic was halted, and this was the beginning of the filovirus family. You can see why they're named that. They look like the string-like pattern that appeared on electron microscopy. That would be, of course, part of the stuff, when you talk about staff, space, and systems, required to identify a new pathogen. And Ebola became the next in line in 1976 and was named after a river that flowed by this so-called mission hospital. Next slide. The new, of course, around this means in a medical desert, you cannot identify a new pathogen if you don't have the tools of the trade. And you can also make enormous but very patterned mistakes in explaining why this is happening. In late 2013, and this is just the hypothesis, right? A child was said to fall ill in a small village in Guinea. And like most places in the medical desert, people travel to medical facilities wherever they are. They also seek care, as every anthropologist knows, from a variety of other sources. Between December 2013 and March 2014, there were investigations by local authorities in Guinea trying to understand what was doing this. But here's the question for the clinicians and the students. An acute febrile illness that causes high fevers, diarrhea, nausea, vomiting, headache, those are the cardinal symptoms, not hemorrhage, right? Could have a differential so long that without the staff, space, and systems, you're just not going to know what it was. And that is what came to happen. But interestingly enough, when the zoonosis connection was made, and this is an old colonial trope as well, an epidemic is by definition from person to person. The spillover event can happen once, twice, but this is person-to-person transmission of a pathogen that is spread, tragically enough, through caregiving. And caregiving in the clinical desert means caregiving without the proper protective equipment. And instead of a rush to help provide the staff, space, and systems, one of the things that we got, there was a focus on disease control, not clinical management. And one of the things that we first heard was, the natives, this is still the word used in Sierra Leone and elsewhere in West Africa, had to stop doing these silly and dangerous things they were doing, like eating bushmeat, or thinking that Ebola isn't real. These pictures, by the way, are taken, one's from Liberia and the others from Sierra Leone, and they're probably funded by your tax dollars, the health information campaigns. They're incorrect for lots of reasons. One of them being it's not entirely clear that what one thinks of the etiology of an illness in Honolulu or in Sierra Leone or here in Rwanda is as important in the midst of an epidemic as trying to save more lives. And that was a tragic mistake that has its roots in colonial rule. Next slide. So what makes a clinical desert? I work in a hospital that many of you have visited, and it's not an enormous hospital in terms of beds. There are bigger ones in the world, and even in Boston, but it is well resourced. There are probably thousands of nurses who work there. The internal medicine faculty on which I serve has 800 faculty. The budget is in the billions of dollars a year, but this is the place where Partners in Health is headquartered now, Koidu Government Hospital, after the war. Of course, I'm going to be talking about the war, but to try and understand how a medical desert is created requires the help of historians, and particularly, in my experience, African historians. And I have many friends and colleagues at Harvard and here in Rwanda who will answer this question even in print. Well, that's obvious. The slave trades are what started the impoverishment of the region. Excuse me. And remember that this went on for centuries, even though Freetown itself, as Monrovia, the capital of Liberia, were established as abolitionist outposts at a very troubled time. Next slide, please. Let me get some water. Sorry, I need aspiration precautions. That's a sore subject right here in the hospital right now. A quick story. Ronald Ross, born in imperial splendor in India, which was the largest colony in the world, where the vast majority of colonized people lived, won a Nobel Prize in the late 19th century for identifying, probably with the help of unknown others, the life cycle of the malaria parasite. And when he left India, he went back to establish what sometimes was called tropical medicine. There are a number of these in the UK. They still are called, some of them, what the term was used at the time, imperial medicine. And he was sent to the empire's most malarious outpost, Sierra Leone, where if you look at, again, talk to historians, the number of governors and colonial officials who died of malaria, probable malaria at the time, was much more than in their other outposts, which again stretched across the world, as you all know. And one of the recommendations he made, some of them seem sensible, but for example, draining standing water, using a larvicide, bed nets. The other was to move Europeans up into a hill station, which of course would protect the white. The idea was that it would protect the white, the British, the fair complected, who were responsible for giving the area the moniker, the white man's grave, when of course the graves there were full of Africans and there were very few whites, but they actually did this. And these buildings stand to this day, and even built a narrow gauge train track to take the colonial officials up into the hill station. Now, as many of you know, Anopheles mosquitoes are night feeders, but they can fly. and they could also ride that train fare free up the hill. And so the project was a total failure, even in the eyes of the most ardent apologists for colonial rule. But it also hardened resentment, as you might imagine, between the white minority and even the Creole-speaking business folk of Freetown, to say nothing of the natives who weren't considered at all. Next slide. So control over care in the 21st century is where I'm going. But I just want to remember the last time we had a great pandemic, as far as we know, remember the picture that I showed you of the patient in the Ebola Treatment Unit. And since my former student and colleague is up here somewhere, I asked him to find the Lagos standard, the actual text, which he did find. And the Lagos standard, like a number of African newspapers, was not always dominated by the colonial rulers, but by the Creole elites who were able sometimes to speak quite clearly. And I won't read this out loud from October 2, 1918, but you could be describing exactly what I saw in West Africa in 2014. And this worldwide pandemic was a disaster, as everyone knows, but it probably arrived to Freetown. In fact, some people thought it originated in Freetown for this reason, on the HMS Mantua, which was a converted ocean liner, as many were during the war, protecting a fleet. And they were going to Sierra Leone, not only because the Suez Canal was closed by the Ottomans and their allies, but because they needed gold, they needed coal, the primary fuel of the empire, and the region was called the Gold Coast for a reason. When the Mantua docked in August, after leaving Plymouth in August of 1918, within weeks, all of the people who fueled the coaling people who were Sierra Leonean, names unknown, fell sick, and catastrophically, within a few weeks, 4% of Freetown's population was dead. And it was like this across the continent, particularly on the coastal regions, but spread inland through new rail routes that hadn't existed in the past. This was, in the eyes of some historians, the most devastating of many noxious forces, including even colonial rule and the brutality that was used to suppress resistance to it. Next slide. So why go back and back? The history of colonial rule on this continent and in many others was made plenty clear by the English, the French, and the Germans, to speak largely of this continent. For England, as I mentioned, the primary fuels of the empire were coal and then oil. But before that, the extraction included all of the bounty above the earth, the trees, and that below it, and the discovery of diamonds right there in the area where Partners in Health is centered, Koidu, which didn't occur until after World War I, made many people very rich. What it didn't do is make Sierra Leoneans rich, but the extractive trades are really central to understanding how a clinical desert was made. My hypothesis would be that in the 17th century, maybe 18th century, a lot of the world was a medical desert. So how did this great diversion beyond slavery come to continue well into the era of what Seiji and others and I have talked about as structural adjustment? Next slide. In next door, in Liberia, next slide. Next door in Liberia, going back to the transnational political economy, after the war, about 80%, 70% of all automobiles were in the United States, where the manufacturing occurred. The one problem which caused outrage among the Ford family and Firestone families was that the British controlled a monopoly on rubber. Various attempts to grow rubber in One place in Brazil, modestly named Fordlandia, failed. Chiapas, Mexico, failed. Revolt, labor revolt, strife. But they found in Liberia an abandoned rubber grove and turned it into what became the world's largest rubber plantation, negotiating a 100-year deal to control this land, which continues to this today. And this is what broke the British monopoly on rubber and fueled the American part of the American automobile manufacturing. And it became central. So now we're getting to the point, the stage where the extraction has gone on so long, the profits extracted are so great that you have a clinical desert. And I would just say, since I'm speaking at John Burns, just think, in 200 years, the British established all of 0 medical schools in Sierra Leone and not a single nursing school either. They also banned Black doctors from the colonial medical system, which was already so grievously understaffed. The situation in many ways was worse in Liberia, which was the only republic not under colonial rule until the Americans made it informal colonial rule, in part with the help of the Firestone Rubber Company. Next slide. So now, you don't have time in the middle of clinical work to be thinking about this. I certainly didn't know these things, and I wasn't invited to Sierra Leone and Liberia to contemplate them either. But it's important to understand that right before, after all this, the brief period of after independence, which is not when structural adjustment plans were proposed, which again proposed further cuts in already anemic budgets for healthcare and education. It's hard to believe, looking back at the history, that war would not occur, and it did. And this was a particularly devastating war. I've used the singular. Most people believe that the Sierra Leonean and Liberian wars, or many people, were really won, as diamonds fueled them both. But it became famous for a number of grisly, amputations, for example, child soldiers. But this was a transnational war, well fueled by modern weapons and funded by the extractive trades. The second picture is Partners in Health's headquarters in Harper, Liberia. And it looked to me the first time I went there that the war was just over, but it still looks like this today. I'm happy to say that there have been a lot of improvements in the medical arena, but the impact of this was right before the explosion of Ebola. Next slide, please. So now the stage is set, and for even more grotesquerie, since we measure the economic health of a nation, not as we should, but by growth of GDP, guess what the number 1 country in the world was the year before Ebola hit? Sierra Leone. This myopic way of looking at health is obviously one that people in our professions can't accept. And the drumbeat about the superstitious practices of the natives continue. The towns here in the Guinea forest regions, by the way, in that forest regions, the people are still termed from the capital forestier. It was at one point in post-independence a capital crime to fell a tree if you were one of the people living and farming among them. And it was okay for the logging industry to continue, which of course is related to the ecological disruption that is seen along with the social disruption with almost every outbreak of Ebola. And most of them are probably not even documented because you're in the middle of a clinical desert, which is a public health desert. Next slide. So how did it spread? Well, let me just give you an example. My first trip to Sierra Leone was in June of 2014. And we weren't going there to respond to Ebola. We were going there because we had planned a Lancet commission on surgical care in resource-poor settings. A number of my colleagues who are surgeons, anesthesiologists, obstetricians said, because in March 2014, the pathogen causing these acute febrile epidemics was finally identified as Ebola. Of course, on the front pages of America's news magazines and many others, there was more exoticization about bushmeat, but I only knew 4 Sierra Leoneans. I'm a little embarrassed to say all physicians. One, my student, Byler Berry, who I'm happy to tell you is alive and well. The other, the sadly famous Humar Khan, who became Sierra Leone's Ebola czar and soon fell to it. And one of the surgeons who helped host us, Martin Salia. That was in the summer of June of 2014. We left from here in Rwanda, quite a large delegation. And by November, 2 of these 3 were dead of Ebola. And we knew that they had contracted the disease in the course of caregiving, but it was the same story for those shut out of modern medicine. Next slide. The next slide is of 3 of our patients, and it was a story that was similar elsewhere. The young woman on the left, I think that's my left, and in the middle, her husband. They had a little baby, and on the right, her best friend. The grandfather of the woman who lost her baby to Ebola shortly there, just before this, her grandfather was a traditional healer. There's a million names for that. I'm sorry to be speaking in front of my anthropology friends and use such a vague term. He fell ill because, of course, he was a frontline worker, a traditional healer. His own son, her father, went to care for him in the, as they say, the village. He got sick, came home to Freetown. Of course, his daughter took care of him. Her best friend helped. The father of her baby helped to bury him, and all of them got sick with Ebola. And they lived, I'd love to claim some credit, but they lived because they were young and healthy and able to choke back what was recommended by international standard setting bodies as the sole treatment for a disease often characterized by vomiting and massive fluid losses up to 10 liters a day. We only know that from the Americans who were transferred back to Emory, Bethesda, Nebraska. But the recommendation by, including the largest medical humanitarian organization in the world, was oral rehydration salts, and kind of serve yourself, like in that Ebola treatment unit that is obviously an isolation facility and little more. And this story we heard again and again among the people we cared for. Next slide. Now, how do you treat massive fluid losses? Especially if someone is vomiting. Well, you need IV therapy. You need a central line if you can get it. People have malaria. They have concurrent infections. They have gut damage. They have secondary infections from the gut. The same kind of things that you would expect, right? So you need quite a bit, but it certainly would be considered paltry in any emergency room in Hawaii. And that's what explains the vast differential case fatality rates of Ebola. Not cultural practices, but if they're cultural practices, they were our own. And I'm talking about the international development and humanitarian responders. One of the tragedies of this, and it went on so long, much more than a year, and it will happen again, is that the case fatality rate at the end of the epidemic was just as high as at the beginning. And for the Americans and most Europeans, including, I'm not saying they're all white Europeans, but people who were medevaced, including a Cuban friend of mine. Cuba, of course, sent quite a few clinicians to help and worked in the same Ebola treatment unit that we did, was medevac to Geneva. None of the Americans died. And again, here comes a rush of false hypotheses about cultural practices, genetic and hereditary susceptibility, the same ones that were circulated under colonial rule, perhaps sometimes more sophisticated. I mean, it is true that so-called traditional funerary practice, I should just say funerals, burying the dead, were among the chief causes of transmission, that and caregiving, but across the world, including, a patient we lost last night, across the world, the standard is for the family to prepare the dead for burial and to inter them if that's what they do. And that's what they do in West Africa. So again, if you want to call these bizarre cultural practices, then they're global ones. And the amazing thing to me was that this was, I'm not saying shrugged off. A lot of very brave people went to respond. I admire them all. But to not understand what was going on, why some patients lived and some patients died, still feels inexcusable to me. Next, please. Now here are the messages we got from the chief standard setting body of the world and the most well prepared Ebola responders by their own admission, certainly the most experienced. And let me just ask you, if you saw this, all over in posters and on signs, no cure, fatal in 90% of cases, there isn't much you can do. Don't even try to help deliver a baby. Some of these guidelines are still online if you'd like to look. I would just ask you, I call this clinical nihilism. There are probably many other terms for it, but it certainly is not very encouraging to improve the quality of care. And it's why Ebola treatment units were really Ebola isolation units designed to stop transmission rather than to avert mortality. And that's what came to pass. Next slide. However, many fought back. I mean, and again, I don't want to tar any particular organization. I have respect for all of them. But the Sierra Leonean doctors, and this was at, a lot of them were military doctors. This was at a police station that was commandeered to make what became the largest Ebola treatment unit. We were working in rural areas, as you might imagine, if you know Partners in Health, but they did not follow the recommendations of oral rehydration salts exclusively. They used fluid resuscitation, antibiotics empirically, vitamin K, antimalarial treatments empirically, and every month, and the patients, some of the patients I got to know were there in the earliest and worst time, but every month there was improvement. And by Christmas, we were able to review a letter that was submitted to the New England Journal of Medicine. And by Christmas 2014, or the end of the year, it was quite clear that they were seeing significant drops in case fatality. This is in a city, and there was easier referral, of course, because of this empiric regimen and more aggressive treatment. And that's what we hope to see for the rest of the epidemic. But sadly, this battle continued on, and I think it's still continuing to this day. In other words, what is it a battle about? And I'll speak about this more tomorrow, or whenever today becomes tomorrow there. This is a battle about the standards of care, and this is socialization for scarcity on behalf of other people, and they're usually Black and brown people. Next slide. So again, I won't spend a lot of time on this. This is not rocket science. Safe supportive care, even without intensive care, it is our contention that it would have saved a great number, and surely the majority of these patients. I mean, how could it be that one friend in particular, who was airlifted to Emory, and again documented to lose up to 20 liters of fluid a day because he was in the ICU there. And he happened to have been born in Africa, in fact. He's an American infectious disease doctor. How exactly could that be, that there was some different physiology for the natives, again, he having been born on that continent, and the rest of us. Safe supportive care is what's required. The safety requires PPE, of course, but really, if you can extract all that latex, diamonds, coal from the region, hardwoods, I could go on. It seemed not too much to ask that we push for higher standards of care and real care as opposed to only isolation as one of the primary goals. There's a lot of reasons to want to do that, many of them just human decency, but how many people do you think you could isolate in a center if they knew that they were not going to receive treatment? And we know the answer to that question as well. Next slide. I want to close by just mentioning the Partners in Health response, and I have gratitude to all those who helped. We were looking largely for experienced nurses. Imagine having the kind of nurses we have in our hospitals in Honolulu and in Boston, who spend their days and nights putting in IVs. Long lines alone would have helped. The list of people was long. We called in international volunteers, which we had done before after the earthquake in Haiti. And it was not a surprise to us that many hundreds of people wanted to sign up. Sometimes people would say, well, I'm scared to serve. And I would say, well, anybody in their right mind would be scared. We're all scared. There are so many different ways to help. And we had a lot of people help by covering the shifts of others who did wish to pitch in. In fact, my colleague, Jean Richardson, has been invited along with Maxine Burnett as speakers in this series. And Jean Richardson is another one of those, he would object to the word hero, but another one of those hard workers who pitched in. And I met him for the first time in an Ebola treatment unit in Sierra Leone. And now we work together at Harvard and elsewhere. And he's responded to Ebola outbreaks right across the border here in Rwanda. And I hope we have some time over the course of the next 2 days to talk about the differences we saw on both sides of that border, this one in Rwanda and right across a few miles from here in the Congo. Next slide. The two tasks, of course, were to save lives and prevent spread, right? It's not one or the other. Without integration of prevention and care, you can't do this work. You couldn't do it with HIV. You can't do it with COVID. When people fall ill, what they're looking for is expert mercy. And as has been said already by Dr. Pohl and will be said, and that's why so many of us went into nursing and medicine in the first place. You also need stuff. This baby, who is thought to have died along with the rest of her family, but found to be alive by a burial team, was admitted on Christmas Eve 2014, but they couldn't get an IV into her. And so they did what we would do in Honolulu or in Boston. They used an intraosseous needle and saved her life. She was the star of the ward, by the way. But it's just hard for me to imagine as a clinician that you can save lives without even with oral rehydration salts alone. For those who didn't have a lot of symptoms, of course, as we say, don't leave home without it. It's good for everything, right? Oral rehydration. This was served lukewarm and served usually by the patients themselves in these so-called treatment units. But if it worked, great, and it reduced the risk of transmission. But the entire point of sending health professionals and PPE there was to take care of these patients. And so we were pretty astounded when the more larger and influential organizations recommended a no-touch policy, literally, no touch with PPE. So it was a clinical disaster for very clinical reasons that, in my rule, are rooted in this control over care logic that dominated colonial medicine, at least on this continent. Next slide. This is straightforward. We didn't want to work in these shitty places. And this was an abandoned vocational school. Who abandons a vocational school in the middle of Sierra Leone? This was in a rural area. It had been set up after the war after demobilization and disarmament efforts, which ultimately did end the war after a horrible decade. And not only was there no morgue, there was no electricity, no drainage, but about 8% of all of Sierra Leone's Ebola survivors walked out of this or were carried out of this unit. Next slide. And I'd like to credit especially Sheila Davis, who was a great nurse, research nurse, who I got to meet 20 years ago at the Mass General when we were still in training. She led the Partners in Health Ebola response from Boston and is now the CEO of Partners in Health, and is she would be a great speaker in this series. We all admire her so much. And we focused on what we were sent to do to prevent transmission, of course, but to provide care and to reopen all the shuttered facilities that we could, meaning district hospitals, health posts. And we ended up spread over the epicenter of in Sierra Leone, the epicenter of the epidemic. By the time we arrived was not the place we intended to work with our colleague, Byler Berry, Kano, or the Diamond District, but it had spread west to the city. Freetown at the time of our arrival was the most Ebola afflicted city in the world and remained that way for a while. Monrovia had been earlier, and we were sent to the most rural region. I showed you the picture from Harper, which is in Maryland. Very interesting history of the place. It was founded by Americans, Black Americans, many of them freed slaves back in the early 19th century. Still a clinical desert. Next slide, please. Now, this is my last slide. It's my thank you slide, and it looked a lot like the picture that Dr. Pohl showed. When you think of emergencies in this country, and this is where I'm sitting, just a few hundred yards from this beautiful building, looking when light comes up at a magnificent volcano that will make me think of you. We think about all the billions of dollars that end up in emergency responses. And I've lived through some painful ones, particularly one in 2010 in Haiti. But what never happens afterwards? And that is, I can't say rebuilding health systems if they were never built under colonial rule, although the Sierra Leoneans in the 70s and 80s began to try, right? And in Rwanda, after what happened after 1994, I'm embarrassed to say that I expressed privately, of course, because I had no experience here back then, the wonder, could you ever recover from the genocide against the Tutsi? Could you imagine a recovery from that? Fortunately, my opinion on that matter didn't matter a bit. I was involved in working in Haiti and Peru, but something miraculous has happened here. And if you want to look at the medical responses, rolling out a national healthcare system focused on the most vulnerable, who happen to be poor and rural, and focusing on the leading killers, which are not only vaccine preventable childhood diseases, but diseases like HIV and TB, which can't be responded to with a control over care paradigm, which, as you know, had been proposed by, again, many international standard setting bodies. And the language was, Africans don't have watches, they can't tell time, they can't use ARVs. Thankfully, of course, that's all bullshit, but thankfully, there were some people, and I gotta say, I was surprised when George W. Bush, listened to the pleas of AIDS activists, as many others, and launched what became the largest real medical humanitarian project in human history, with no rival under colonial rule, not for sleeping sickness or anything other, and that was PEPFAR. It has saved tens of millions of lives and still is. And in Rwanda, where the money was used very effectively to strengthen their health system in general, in the 3 districts in which Partners in Health has worked over the last soon couple of decades, I don't think there's been a single case of mother-to-child transmission that's been documented here. I certainly haven't seen any. And we expected, when I was in training in ID, to see a major American pediatric HIV epidemic as well. And that we didn't have, again, because we did not separate disease control and care. And this generation, this is our white coat ceremony last December. Most of our students are young women. They're younger than yours because they go for their medical degree right after high school here very often. And I've been working with them every day, rounding with them every day. And I can tell you, they're as good as students I've had anywhere else or better. This is an international faculty, mostly African, but I sure hope that my friend Seiji comes here soon, we have a vibrant community health department, and if there are other faculty subspecialists who wish to contribute to this amazing experiment that will work. When you have a platform, meaning a delivery platform, in this case, right across from me, soon I'll be rounding at Butaro District Hospital, which Partners in Health built, but built for the Ministry of Health. It's a public safety net hospital that is becoming a teaching hospital. It's also the National Cancer Referral Center, which was scoffed at by the same people who thought it was impossible to treat AIDS in Africa or actually manage Ebola properly. But within a few years, up to 70% of all of Rwanda, the patients in Rwanda's National Cancer Registry were treated here in this rural area, which just 13 years ago not only had no hospital, but no electricity, water, or doctor. Now the epicenter of a burgeoning social justice university that is called the University of Global Health Equity on Purpose. So I'll stop there, and I hope I haven't gone over or sound manic this early in the morning, but it's as sorry as I am not to be there and to miss my friends Gregory and Seiji, among others. I'm very honored to have been invited to give this speech. Thank you.
Paul, this is Seiji. Good to see you. Can whoever is in charge of the okay, thank you. So perhaps anybody on Zoom who would like to ask a question of Dr. Farmer, if they can turn on their cameras. We have some folks here in the room. Anybody here would like to ask a question?
I hope I didn't. You're all good. Okay. Thank you so much for the talk, Dr. Farmer. So I'm a first-year medical student, and I had the chance to read Mountains Before Mountains relatively recently. And during this talk and in that book, I think you talk about the successes of trying to balance, I guess, going into these colonized settings and providing care without, I guess, perpetuating the history and the violence of colonization. I'd also like to hear about some of, I guess, the quote unquote, I guess, failures in trying to maintain that balance, if you can. Like, what are some adverse effects that you felt that you personally, or not personally, but that you've caused in trying to do good for these places have been? Thank you.
Thank you so much. And I didn't catch your name. I don't know if you're not popping up on my.
Oh yeah. My name is Scott Nishioka. I'm a first-year medical student at Burns.
Hey, Scott. Well, let me just be very candid. After close to 40 years in Haiti, I went there in 1983, and of course with no skills of any value. I tried hard. First of all, there are plenty of ways to prevent that harm. First of all, let me start with that. Partners in Health in Haiti is the largest health NGO there as well, over 7,000 people, and they're all Haitian. All right. Yes, we have people coming from the United States, and some of our greatest champions clinically. I work very closely with a lot of nephrologists, and one guy from Dartmouth that was a division chief there is just 10 years of training. That's the second part, right? When I went there, and here's my mea culpa. When I went there as a young man, again, I'm glad I did. I feel very fortunate. What good we did, and I was working with an all Haitian group back then as well. But I was working in a church-affiliated clinic, and it wasn't long, even before I started medical school the next year and was going back and forth, it wasn't long before we had to wonder, are we doing any good at all? You don't have the staff, you don't have the stuff, you don't have the space, you don't have the systems, you don't have the support patients need, any fee for service, which was a standard across the country. And part of that, I think, is related to the American proximity and influence in Haiti. So even though, I learned a great deal, it's hard for me to look back at that first decade of my own experience in Haiti and feel like that we did any good at all, except learning a lot about how not to practice medicine. So the changes that we made included working to build up the public infrastructure, some of which had been built during the American occupation, which ended in 1934, and to focus our efforts, again, integrating prevention and care. When we could later on use any resources that were vertical in nature, that is for AIDS or TB or something, women's health, and strengthen the primary care system. It's not rocket science. But one thing I will say, I'm not going to do the usual anthropology thing and say, well, I learned the language, my wife's Asian, I could do all that. It's true. But I don't, my Russian's terrible, and I had a terrific experience and for 15 years working in prisons there and seeing the same kind of dramatic responses that I mentioned in Rwanda inside the prison system, right? So, if I were to give advice, even yesterday this happened at the hospital, I would say to my non-Rwandan colleagues, and again, a lot of them are Americans, not here, most of them are from elsewhere in Africa, Ethiopia, Nigeria, the neighboring countries, you really need to shut up and be quiet sometimes and just listen to people. You don't have to say shut up. I actually don't say it that way. To assume as many we've had some huge projects here that have been very successful, not partners in health projects, but national projects to train subspecialists. And every year for several years, I got to do their orientation session. And I would get the question, we don't hear a lot about white savior complex. In my experience here, that's a discussion I hear in American universities or universities in general, although these are the ones that I'm familiar with. But, in warning them in one way or another, what I say is, do not assume that your Rwandan colleagues care less about the patients than you do, or aren't, as alarmed by yesterday. It was a question of, if we'd have an anesthesia machine. I got an email from one of my own trainees from the Brigham, who's on the faculty elsewhere now, great guy, who wrote me and said some of our fellows in OB who are going to be working with Partners in Health Rwanda have heard that there's no anesthesia machine. So I wrote the director, who is of course a Rwandan physician, and he said, we've already ordered them. They'll be there well before any of you do. And my friend didn't have to say anything other than thank you, but he said, yeah, you've warned us over the years, not to assume, that there are less ardent desires for good outcomes among our African colleagues. That's not very well tolerated here or in Haiti, where I learned these lessons. They've been my greatest teachers. And in fact, the setup here is exactly the same across all of our systems. Our employees, and it's huge here too, 6,000, they're Rwandans. By the time we built Butaro Hospital and the Cancer Center, within a year or two, 70% of all the salaries at the hospital were paid by the Ministry of Health. Now that's an unusual degree of, well, unprecedented for us. The degree of support we get from the Rwandan government, the Ministry of Health, you could say, well, yeah, you built it for them, but what a privilege, right? Those are the rules we follow. When we have disagreements, we remember that we're guests. But usually, I don't have an experience other than the Haiti earthquake and seeing it. Partners in Health, of course, was Zami La Santé, a Haitian organization, even older than Partners in Health, and really the foundings of Partners in Health are in Haiti, which, as you know, has a history as an anti-colonial, anti-racist, the anti-colonial, anti-slavery, anti-racist movement of the late 18th century, and the only one that led to an independent country. It's a great place to learn lessons like that. The cultural issues that you bring up, of course, they're all over the world. I'm sure you see them in Hawaii. Our students learn about, why they shouldn't scorn or denigrate traditional healers. Their parents and grandparents had to avail themselves of them, of course, because this place too was a clinical desert just a couple decades ago. So there's a lot of ways to do that. The way I wish that more NGOs would do it would be not to build these parallel systems, which are often not very good anyway, but to work with people to make a national safety net and build national institutions like this university. Even though it is an international university, it's Rwandan, and the next one going up is in Haiti.
Paul, a couple more questions if you can stay with us another minute or two.
I'm not in a rush. I don't have rounds for 2 more hours.
The first one here is from Morgan Cowger, a psychiatry resident. She says, yes, how do we globally change structural racism?
Well, that's a great question. And, when you look at Frantz Fanon's critique of American Black intellectuals, one of the things he worried about was something I just hinted at, that this is not just a university discussion. Who are the primary victims of structural racism? And if you're going to weight the damage, and we know a lot more about how it works in the United States with redlining, with household wealth, the most severe damage is structured by racism, poverty, and gender inequality together, right? So, and I would just say here in Rwanda, where there are different kinds of histories of ethnic divisionism, right? Everybody here, we structural racism, a lot of the first year of their training. So again, you're a psychiatry resident. So I'm just gonna think a little bit about the value of training people to understand how structural violence in general works, right? But let me say something I find disturbingly absent from discussions of decolonizing global health. If I am correct, and I know I'm right about the places in which I work, there was no colonial medicine. It was a control over care paradigm. So if in Sierra Leone there were no medical school or nursing schools founded by the British in 200 years, part of the job surely is to found medical and nursing schools. And whether or not you want to call that decolonizing global health, or mitigation measures, it seems to me that I should have listened in Haiti in that first decade when I heard people say, well, hell, I'd like to go to Harvard Medical School too. It's not like I scoffed, but I just saw no possibility. And there's, and I had good reason to think that they wouldn't, be able to get into Harvard Medical School. But that didn't mean we couldn't build one. That didn't mean we couldn't support the building of medical schools. That didn't mean we couldn't offer something that had not been on offer in rural Haiti, which is medical care. And so finally, I think since I'm speaking to a psychiatrist, I just think we have to work harder to eradicate racism from our own souls, psyches, etc. And the way I've described it here in this lecture, and what I would like everyone to look for, is lower expectations on behalf of other people. You can't treat cancer in Haiti, in Rwanda. You can't deal with leukemia. You can't have an ICU. These are in our own profession, and they're coming from experts. They're not coming from, the patient saying, "Oh well, I'm a Haitian woman. I have AIDS. I'm not cost effective to save." Is that racism? I think it is. It's better described as structural racism, and I can't even attribute any motivations to the people who write these things. Some of them are friends of mine, and I know they would be mortified to think that they were being racist. But the fundamental outcome of setting your expectations lower on behalf of other people who are mostly Black and brown is something that we need to attack with material support. And call it reparations if you like, that's fine with me. The reparative material And the solidarity has to be, the reparations and the solidarity has to be material, staff, stuff, space, systems, and support. And, I think, we've tried to build that into Partners in Health's work. If there's a non-Liberian director in Liberia, you can bet he's Haitian, right? I haven't heard complaints, and he's an anti-racist doctor himself, like many of my Haitian colleagues. So I think we need to shift the conversation a bit to what we're hearing from poor people who, again, in my experience around here, are saying we want schools for our children, we want clean water, we want jobs, and we'd like to have our kids go to places like the University of Global Health Equity. I met a nurse here 15 years ago on my first trip. As I said, no hospital, no doctor, no water, no electricity. Her son, and I think her youngest son, she was an LPN, she wasn't an RN. Her son is a first-year medical school here, a medical student here. I mean, to me, that's listening to people when they're quite explicit about some of the things they'd like to have, which look a lot like the things we want as well.
Paul, there's a question here from Kyungmoo
Thank you,
Kim.
Morgan.
Kyungmoo Kim, I believe you're second year, if I'm correct. He says, in some resource poor settings with concerns of autocracy or oppression,
Yeah.
what are some of the ways to balance usage of public health tools like surveillance and social distancing, and making sure that they aren't used to achieve nefarious politics or human rights abuses?
Thank you, Kyungmoo. That's a great question, and one that all of us are interested in. What I wanted to say is that, for example, in Rwanda, the reason that the rate of vaccination for COVID is higher here than probably anywhere on the continent, while it's one of the poorer countries, is not to do with autocracy, but actually trust in the government. Just across the border in the Congo, where these are linguistically and culturally, to me, I would say identical people, right? It's just an artificial colonial border. Of course, things diverge over time, but it's not very striking to this anthropologist. Efforts to provide the new and effective Ebola vaccine that was probably the saving grace of the West African epidemic. Your former guest, Gene Richardson, can tell you about this. This was met by efforts to flee. So villages emptied out and wouldn't take the vaccine. On the other side of the border, where you read these international news stories about, the autocracy, or it's just ridiculous. There's a great deal of trust. I've lived and worked here for a long time. 2 of my kids were born here. I think I'm, qualified to say that I wish we had this level of trust in public health authorities in the United States that you can see here. And that's been key to their response and why it's been effective here. But to answer your question, Kyungmoo, if we think that surveillance and disease control are the same things as caregiving, then we're going to make the same mistakes we keep on making with HIV. Remember, can't treat Africans. With Ebola, again, basically the same thing, oral rehydration salts only. We have to provide evidence, humble evidence of caring about people. And to quote another old white guy from Harvard, I think it was Francis Peabody, who said, the secret of care for the patient is caring for the patients. And whether they're Russian prisoners whose language I really don't speak, or people in rural Malawi, I think showing up, the ministry of showing up and showing that you care is one of the best antidotes to mistrust. Now, I have also worked in places, Guatemala after a genocidal spree, after too many military coups to count in Haiti. But because we have been caregivers We were probably spared some of the violence just because we're the only show in town. We usually work in rural areas, right? And there have been a lot of problems, but they haven't been directed at the nurses and doctors who are providing care every day. As I mentioned, those are primarily people from Haiti, Malawi, Rwanda, Lesotho, et cetera. Our staff in Russia is all Russian. You know, humility, you know, there were years ago, even at John Burns, where, you know, you'd hear people suggesting the study of cultural competence or competency. I would say that is not the way to go at all, that what we need is cultural humility. And yeah, it helps to know more about the place you're working, but I've been amazed at how quickly people can tell if you're caring for them or merely worried about surveillance numbers, about disease control without care. And that's been a pathology on this continent for the last century. Great question.
Thank you very much.
Paul, you know, I think you've actually kind of answered in your answer there to the next question, which is from looks like the Hawaii Family Medicine Residency.
Yeah, that's a great question.
How do you overcome the local resistance toward outside healthcare or organized healthcare? And you mentioned Gene Richardson, who I became friends with when he was studying here in Hawaii. And in his book Epidemic Illusions, he mentions that you know, when a guy pulls up looking like him, a tall white guy, a tall skinny white guy out of a white NGO SUV, and the people flee. You know, what can be done about that? And yeah.
Well, let me just
go ahead.
Let me just say, and first of all, I think it's a great question. But remember, if you start, as Partners in Health was lucky to do, in a clinical desert in a rural area, I mean, we just don't see it. Nobody was resisting organized healthcare. They were saying, we don't have it. We would like it. That was Haiti. You know, I've written a lot about that, and I feel like I'm qualified to do that. The same thing in Rwanda. There were 4 districts of 30 with no district hospitals. We were sent to 3 of the 4. You know, all we heard was clamoring for these services from people previously denied them. And again, I've mentioned that, our staff, even when we first got here, was largely Rwandan. Now it's all Rwandan. But it's not like there's no mistrust between rural people we serve and the urban folks who've gone through medical school or nursing school in the cities. And it's even worse across Latin America. So I hope you don't think I'm deluded when I say that living in a village in rural Haiti, when you're the only non-Haitian, I got a lot less resistance than the folks that the people, and I still live in the same place there, called, the Haitian word for it is bourgeois, just meaning urban elites who didn't care enough about the rural poor. And that varies from place to place. I've seen less of that in Malawi. There should be a lot of it here as Rwanda does so well economically compared to many of its neighbors. There's a growing, burgeoning Rwandan elite. But I work with a lot of these people up here. And of course, they're at a social justice university. And I'm so impressed by what they're doing. So I would say, and again, I don't want to sound naive, that resistance towards outside healthcare, organized healthcare, has been one of the least striking things I've seen in my life. What I've heard is a clamor requesting quality healthcare again and again and again. I've seen it in Navajo Nation, seen it in rural parts of the United States. Other people have other experiences. I don't have a lot of experience of stepping out of a big SUV, although I maybe am a kind of tall, skinny white guy, because, these are not short-term engagements. Those are tough, I've no doubt. But when I invite people from University of Hawaii here to serve on faculty, they would be part of a system that has been functioning here over a decade, just up here, and for almost 20 years. Those long-term engagements were begun without that kind of resistance and have continued without it either. So I'm interested in this. I'm just saying, I think one of the biggest steps we could do to decolonize global health is actually introduce health services many times for the first time, especially in rural regions of this continent, that is still probably the only one that is largely rural. It won't be for long, but these are not the complaints that we're hearing from our Rwandan colleagues or directly to us.
Paul, I was going to bring it to an end here, but there's one more question, if you wouldn't mind. Alicia Swartz says, how do you find success in encouraging leaders of systems to rethink prevailing assumptions, for example, control over care, cannot treat cancer, yell louder, be more patient or persistent, share more stories? How did George Bush become convinced to institute PEPFAR in 2003?
Well, I'm going to say that I'm going to say that last question for last, because it'd be not speculation. I was, excuse me, I was around when Tony Fauci asked me to go to the White House and talk about this. Excuse me. It's your fault, Seiji. I'm aspirating my tea. I asked him.
It was about 2002, 2003 that, well, it was in 2002 that you and Jim Kim were promoting this.
Yeah, and for many years before that, but it was Tony Fauci who said, you should come up from Haiti like tomorrow and go to the White House. And I said, like, won't they know? Won't I, like, you know, have a drone attack as I walk through the doors? Are you sure? I didn't really say that. There weren't drones back then, you know. I just didn't expect a warm welcome. I will say that I do think, you know, the answer in both cases is to again engage in humble service in treating AIDS, in treating cancer. And just to go to one more story, and I know you guys have other obligations. You know, I've been in, as soon as you open a clinical facility, you're going to see cancer, lots of it, right? Doesn't matter where. If there's no cancer care, you know, as you know, as there isn't or wasn't here, you'll be flooded with patients with late stage cancers, Mets. I mean, some of the patients I saw yesterday who also have infections are just, you know, they've been looking for care in the biomedical sector, by the way, sometimes for years. And this is why we say to our surgeons, don't blame traditional medicine or any of that crap. You know, why does this woman already have a biopsy scar on her breast? Because she's been looking for us, meaning in the medical profession, to help her. But after years of doing this, I was invited to give a keynote speech on in Dublin. Astoundingly, the topic was cancer care. They probably wanted to write cancer control, cancer care in resource poor settings, right? How many times have you heard that term? There are plenty of resource poor settings in Massachusetts too, as we found out during COVID, as we knew before. And I gave my spiel, and they gave me like a whole hour, as you did. And I was talking about, of course, patients, as we did in the White House. I said, don't say you can't treat AIDS. Look at this guy before. Look at this guy after. Look at this girl before. This young woman before. Look after. And I think that was powerful to some in the Bush White House. And you know, I know what he told me after. You know, was that, you know, he found those compelling, and he had been advised by many, not all of his people. They said, you know, when you heard them say it on TV and the news, there's nothing we can do, it's too late, we can only focus on preventing new cases. But some of his advisors said that's not true. They also said that's not Christian. And trust me, I was willing to use any argument that I could bring out. But mostly what we could do, as with cancer care, is say, stop saying you can't do this because it's being done. It's being done by the Haitians. It's being done by the Rwandans. Back to Dublin. So I go give this talk. And one of the people there was from the World Health Organization. And his job, it said on his name tag, and this was not private, like there were a crowd of people around me. And he said, but surely you can't believe that you can treat cancer in rural Africa. And I said, but isn't that your job, to think about that? So I'm saying this, and I'm not even interested in his motivations for saying that, right? But I'm saying sometimes you have to fight back the best way, which is with humble service. Nothing against yelling and shouting. We wouldn't have gotten far with PEPFAR. We wouldn't have gotten anywhere with PEPFAR without AIDS activists. I hope I have made that clear in anything I've said or written about this. The activists, the AIDS activists were the center of it. But what we could do is to say, we know that's not true because here, this is what it looks like in rural Haiti. And imagine if I'd come here 20 years ago and said, what you really need in Rwanda to take care of people with AIDS is more ID doctors like me. I was probably the only ID doctor in the country often. And right now, I'm probably the only ID doctor in northern Rwanda, right? But I didn't say that. I said, what we need is community health workers and the public health system to roll this out to rural areas. And that's what they did. And that's why Rwanda became the first country on this continent to meet what were then defined as universal access to ART. And they've done it with other problems. They've addressed other problems like that as well. So the leaders here, in other words, including the president, they were already advocates for this project. But there have been other places where you get surprise alliances. I will, George W. Bush, has saved a lot of lives from AIDS, that's for sure. And I can't imagine, that without it, we'd be in a very, very dire situation, even this far up north in Africa and devastatingly further south where there's so much labor migration. Again, these are not cultural beliefs. Labor migration is what fuels a lot of the horrible epidemics that we've seen in South Africa, Lesotho, where we're Partners in Health works. So I guess, Alicia, I would say all of the above, but the most neglected one, I think, is humble service to those who need these services and fighting back by saying, don't say this can't be done. I mean, building a university in the middle of a rural area that had no electricity or, just a few years ago, look online and see how beautiful it is. And this place is blossoming. The whole town is becoming a city. And, that's happened in lots of places of the world when you focus on training the abundant local talent, much of it young. I think that's part of the work too. So I know I've gone over, you can tell I've enjoyed myself a lot. I miss you, Gregory and Seiji, and I'm sorry I'm not there, but I'm going to be with you at least on this marvelous technology. And I feel like I am there, especially since I get to see the volcano when the sun comes up. Thank you all so much.
Thank you very much, Paul.
Thank you.
We're going to see you tomorrow.
Is it today, tomorrow? I can't figure that out. I will be there no matter what.
6:30 a.m. your time, I understand.
Oh, well, that's merciful.